institutes like Nimhan Sadyar Cancer Institute and many more. Some of them opted for various fellowship programs and senior residency, and most of them have joined private practice, and few have also chosen their career as teaching faculty. This is a consolidated list of our students who have progressed for higher education. We have significant representation both at the national and state level in professional bodies like Association of Physicians of India, Innovative Physician Forum, Indian Association of Clinical Medicine, and many more. That's all from my side. Now I invite Dr. Arushi Chaudhary for the case. Thank you.
A very good morning to Honorable Emeritus Chairperson, sir, respected dignitaries, teachers, and my dear colleagues. The case for today's CCR is a 67-year-old female with fever and altered sensorium. Patient details. Patient was 67-year-old married female. She was Anganwadi worker by profession. She was a resident of Bharatpur, and informant was husband, and he seemed to be reliable. Chief complaints. Patient presented to us with complaints of weight loss for 4 months, oral ulcers on and off for 3 months, fever with chills for 15 days, headache for 4 days, vomiting for 3 days, abnormal jerky movements of all 4 limbs. There were 2 episodes in last 24 hours, and altered sensorium since 4 hours. History of presenting illness. Patient was apparently asymptomatic 4 months back. Then she started complaining of weight loss, which was significant, that she has lost around 10 kgs in last 4 months. Oral ulcers for last 3 months. They were painful, distributed over tongue, buccal mucosa and lips, and they were self-resolving in nature. Fever for 15 days. It was continuous, high grade and undocumented, and it was associated with chills and relief by medication. Headache for 4 days, which was acute in onset without any aura. It was holocranial, dull aching. It was present throughout the day. It was also associated with recurrent vomiting, and there were no aggravating and relieving factors, and it was transiently relieved by medication. Vomiting for 3 days, which was again acute in onset, associated with nausea and headache, yellow colored with food particles, and there was no blood in vomitus. It was non-projectile in nature, and there were about 4 to 5 episodes in a day. Abnormal involuntary jerky movements of all 4 limbs with associated clenching of teeth, uprolling of eyes, frothing from mouth, bladder incontinence, and tongue bite. Each episode lasted for about 2 to 3 minutes each, and there were 2 such episodes 4 hours apart in last 24 hours. An altered sensorium since last 4 hours. The patient was drowsy but arousable to painful stimuli and was not able to recognize relatives. Negative history. There was no history of cough, nasal congestion, burning micturition, rashes, joint pain. There was no history of genital ulcers or pain abdomen, diarrhea. There was no focal neurological deficit. There were no complaint of diplopia, blurring of vision. There was no history of trauma preceding or during the event, and there were no history of previous seizures. Past history. Patient has no known previous comorbidities. Personal history. Her appetite was decreased since last 4 months. Sleep habits, bowel and bladder habits were regular, and she had no addictions. Now coming to obstetric history, she was gravida 3, para 3 and live 3. They were all normal vaginal deliveries, and she attained menopause at 52 years of age. There was no significant family history. Now drug history, she took some antibiotic for fever and multivitamin for ulcers. So now we have a 67-year-old female with loss of weight and appetite for 4 months, with recurrent oral ulcers for 3 months, with fever with chills for 15 days, headache and with vomiting for 4 days, and seizure followed by altered sensorium since 4 hours. So what are the likely differentials? Anyone from the audience? So now here are some causes of fever with headache and seizures. There are infectious and non-infectious causes. In infectious causes, we can have CNS infections, systemic infections with encephalopathy. Non-infectious, we can have autoimmune conditions, CNS pathologies, others like heat stroke, and vascular disorders like subarachnoid hemorrhage and CVT. Here are some causes of significant weight loss, like in malignancy, GI disorders, endocrine, neurological, cardiac disorders, infections, rheumatological, medications, social, renal insufficiency, and respiratory. So now these are our differentials based on our history. In infectious causes, in CNS infections, we can have meningitis, encephalitis, meningoencephalitis, and brain abscess. In systemic infections with encephalopathy, we can have acquired immunodeficiency syndrome, dengue, scrub typhus, malaria, enteric fever. In non-infectious causes and under autoimmune conditions with super-added infection, like in our case, could be SLE, autoimmune encephalitis, Beckett's disease, hyperthyroid state. In CNS pathologies, we can have acute disseminated encephalomyelitis, primary metastatic brain tumors, and in vascular disorders, we can have subarachnoid hemorrhage and cerebral venous sinus thrombosis. Now coming to examination. In general physical examination, it was unremarkable except for the fact the patient was of average build and was poorly nourished, and there was pallor present, but there were no oral ulcers at the time of presentation. Vitals, she had a pulse rate of 114 per minute and a blood pressure of 106 by 88 millimeters of mercury and temperature of 101.5 degree Fahrenheit with SpO2 of 95% and respiratory rate of 20 per minute. Now systemic examination was again unremarkable. So now coming to central nervous system examination. In higher mental functions, consciousness, patient was drowsy, arousable to painful stimuli, lying on bed at the time of examination and was not cooperative. Orientation, patient was not oriented to time, place or person. Mini mental state examination, memory could not be tested. Speech was incomprehensible and she had a GCS of 9 out of 15, that is E2, V2 and M5. Now coming to cranial nerve examination. Fundus was not suggestive of papilledema. There was no, there was normal disc margin and pupil was normal size and normal reaction. Rest cranial nerves could not be assessed. Now coming to motor system examination in bulk, there was generalized wasting seen, tone. There was normal tone in all 4 limbs. Power, patient was not cooperative, but she was moving all 4 limbs spontaneously, so at least she had a power of 3 by 5 in all 4 limbs. Superficial reflexes were present and bilateral planters were flexor. Deep tendon reflexes were +2 in all 4 limbs, which was again normal. Gait and coordination could not be assessed and there were no involuntary movements seen. Sensory system could not be assessed and cerebellar signs were also could not be assessed. Now coming to signs of mental irritation, patient had neck rigidity with positive Koenig's and Rudinsky sign. So now coming to summarize, we have a 67-year-old female with significant weight loss, recurrent oral ulcers, fever with chills, headache, vomiting, and 2 episodes of seizure followed by altered sensorium. On examination, she had a GCS of E2, V2, M5. She was febrile, pallor was present, patient was drowsy, arousable to painful stimuli, and was not cooperative, and there were signs of mental irritation present. So, what is the likely diagnosis? So now these are differentials, and based on history, we could not rule out anyone. So now, how shall we proceed further? Yes. Yes, exactly. So even our most likely differentials were either meningitis or meningoencephalitis. So here's how we proceeded. So NCCT head was done in emergency room. It was suggestive of vasculitis and it was suggestive of acute infarct and myocarditis, and details will be discussed by radiology. And lumbar puncture wasn't performed under all aseptic precautions. All routine and relevant labs were sent. Now suspecting meningoencephalitis, blood cultures were drawn and patient was started on empirical treatment for the same. We started her on injection dexamethasone, ceftriaxone, vancomycin, acyclovir and injection levetiracetam. On day 2, patient was, there was no improvement in her neurological status. She was still febrile with a maximum recorded temperature of 102.8 degree Fahrenheit. And it was transiently relieved by medication. Now coming to investigations. In CBC, we have neutrophilic leukocytosis with a hemoglobin of 9.1 gram per deciliter with elevated ESR and C-reactive proteins. And PBF was suggestive of normocytic normochromic anemia with neutrophilic leukocytosis with toxic granules. LFT, RFT, urine routine were again within normal limits. Her ultrasound and chest X-ray was also normal. So now coming to CSF study. In CSF pathology, CSF was turbid in appearance. There was no coagulum. There were increased cell count. There were around 1800 cells and predominantly they were all neutrophils. Now coming to biochemistry, we have CSF sugar less than 20 milligram per deciliter and corresponding blood sugar at that time was 109. CSF protein was very high, it was 2030. So now since the serology was negative for dengue, scrub, malaria and enteric fever, so we can rule them out at this point. and even her thyroid profile was normal, and there was and on CT there was no evidence of bleed, so we can also rule out SAH. So factoring in her HIV positivity, rest of her differential other than meningitis, encephalitis and meningoencephalitis seemed less likely. So we decided to reevaluate her differentials and look into cause of CNS manifestations in HIV. In bacterial, we can have pneumococcal meningitis, meningococcal, Neisseria, E. coli, Klebsiella, Listeria and syphilis. Although they were not seen on gram stain, but still we were waiting for CSF cultures. In viral, we can have progressive multifocal leukoencephalopathy, cytomegalovirus, herpes simplex virus and enterovirus. But since CSF encephalitis panel was negative for last 3, so we can also rule them out. On fungal, we can have Cryptococcus meningitis, but since India Inc. was negative for Cryptococcus, we can also rule it out. And histoplasma, aspergillosis and mucormycosis, we were still waiting for CSF cultures to come. And nocardia, it was not seen on modified ZN staining, so we can also rule it out. In parasitic or protozoa, we can have toxoplasmosis or amoebiasis, and in non-infectious causes, we can have aseptic HIV meningitis, but this is a diagnosis of exclusion. So now to rule certain of the differentials out, we ordered MRI. So now I would like to call Dr. Ishika from Department of Radiodiagnosis to proceed with the case.
Good morning, respected teachers, seniors and my dear colleagues. I will be discussing the X-ray, CT and MRI findings of this case. This is the chest X-ray AP view of the patient. There is no bony, the bony cage was normal, bilateral CP angle and lung fields are clear. There was no abnormal pathology seen on chest X-ray. This is the NCCT head of the patient, axial view, which shows that there is lacunar hypodensity in left capsuloganglionic region. This is NCCT head axial view bony window, which shows that there is fluid attenuation in bilateral mastoid air cells, which is more on right side than left side. These are the MRI images of the patient. On T2 weighted axial image, we can see that there is hyperintensity in left putamen region, which is appearing hyperintense on DWI and hypointense on ADC. This is suggestive of acute infarct. Also, we can see that there is fluid level in occipital horns or bilateral lateral ventricles, which are showing diffusion restriction on DWI image. This is suggestive of ependymitis. Normally, the sulci appear hypointense, but in our patient, we can see the sulci are hyperintense and showing contrast enhancement on post-contrast images. This is suggestive of leptomeningitis. Acute infarct is also seen on superolateral aspect of right cerebellar hemisphere. There is also dural enhancement on post-contrast images. Fluid attenuation and hyperintensities are also seen in right mastoid air cells and right middle ear. This is suggestive of right mastoiditis and right otitis media. So the final diagnosis is leptomeningitis, pachymeningitis and vasculitis related infarcts in left putamen and right cerebellar hemisphere. There is also evidence of right mastoiditis and otitis media. I would like to invite Dr. Arushi to continue the presentation.
Thank you, Dr. Ishika. So now, the very next day, while we were busy ruling out other differentials, we got a call from Microbiology department to send a fresh CSF sample, and details of which I would like to call Dr. Shaveta ma'am from Department of Microbiology.
Good morning, everyone. So, as we received the CSF sample, and the CSF sample was sent for the gram staining, ZN staining and India Inc. preparation. On gram staining, we found many irregular structures, and which are resembling, they may be macrophages or they are amoeboid forms. So I asked for the wet mount preparation. On wet mount preparation, we found non-motile irregular structures. So to rule out further possibilities, we want to have a clinical correlation. So we called the medicine department and asked about the history of the patient. The history was suggestive of meningoencephalitis case. So we want to further proceed with our proceedings. So we asked for the repeat fresh sample to be sent to the lab immediately, as Macrophages are usually non-motile and your amoeboid structures are motile. So to look for the motility, we ask for the fresh repeat sample. In the fresh second sample, we perform the unstained wet mount preparation. On the unstained wet mount preparation, we found sluggishly motile trophozoites which are morphologically resembling the trophozoite of Acanthamoeba species. Then we did the gram staining. On gram staining, we found the two trophozoites, one is this and one is this, which are morphologically resembling the trophozoites of Acanthamoeba species. Further, we did the Giemsa staining. On Giemsa staining, again we found the trophozoite forms and cyst form. Since we are able to localize the cyst in the sample, so it rules out the possibility of Naegleria flori, because in the Naegleria flori, first of all, the patient should be competent. Second, there should be a history of swimming. Third, there should be a presence of cyst should not be present in humans. Cyst is only found in the culture sample. So we are ruling further the possibility of Naegleria flori, and they are morphologically resembling the trophozoite and cyst of Acanthamoeba species. Then we did H&E staining. Again, we find the trophozoites. So as per our observation, the microbiological diagnosis is Acanthamoeba species. So what are these basically? They belong to the group of free living amoebae. They are found in fresh water, mud, moist soil, and may infect the man. They are basically aerobic and ubiquitous in distribution. They have 4 genera, that is Naegleria, then Acanthamoeba, Balamuthia, and Sepinia. Now our cases of Acanthamoeba, it is a free living ubiquitous protozoan causing the meningoencephalitis or fetal granulomatous encephalitis in humans. And the mode of transmission is usually unknown, but it is pretty sure that there should not be a contact with the warm water, so there should be not a swimming history. Onset is insidious with a prolonged clinical course, and incubation period is more than 7 days. So for the diagnosis, or we can see life cycle part, include mainly 2 morphological form. First is trophozoite form. It has a size of 20 to 50 micrometer with rough exterior surface with the several spines. That's why they are known as acanthopodia. Acanthopodia helps the trophozoite to have a motility, and hence the organism is named. It has a single nucleus with a central and dense nucleolus and surrounded by little halo. Second form is the double-layered wrinkled ectocyst outside, and inner is the endocyst, and it is a basically spherical structure having a 15 micrometer in the diameter. So the likely diagnosis is Acanthamoeba infection. Now I like to call medicine people to please continue. Thank you.
Thank you, ma'am. So now, summarizing all the information that we have gathered so far, we have a 67-year-old female with fever, headache, vomiting, seizures, with history of weight loss and oral ulcers, and with signs of mental irritation. She had HIV positive status, and her CD4 counts were 154. On CSF, there were visualization of Acanthamoeba trophozoites and cysts, and MRI showed meningitis. So our final diagnosis will be acquired immunodeficiency syndrome stage 3 with amoebic meningoencephalitis. So now I would like to call Dr. Kanika from Department of Neurology to proceed with the case further.
A very good morning to the respected dignitaries, teachers and my colleagues. I am Dr. Kanika Suri from the Department of Neurology. So we got a call from the medicine department to review this particular patient. I would like to brief upon the patient from our point of view. She was a 67-year-old immunosuppressed female coming with a history of 15-day history of fever, headache, recurrent vomiting, seizures, and there were signs of meningeal irritation, clinching us to a clinical diagnosis of meningoencephalitis. Now, upon analyzing her CSF, her proteins were high, up to 2000. Sugar was severely less than 20. Her cells were increased up till 1800 with predominance of neutrophils. AD was slightly on the higher side, and gram stain showed some amoeboid structure. Her CSF was suggestive of meningitis. However, the etiology was inconclusive and was only confirmed after the CSF wet mount, confirming the presence of Acanthamoeba species. Moving further with the neuroimaging MRI brain, the typical findings of amoebic encephalitis present with granulomatous lesions. There could be single, multiple. There could be presence of meningeal enhancement. There could be hemorrhagic foci. There could also be edema and mass effects secondary to the granulomatous lesions, and there could be vasculitis-related infarcts. However, we observed meningeal enhancement and vasculitis-related infarcts in our particular patient. So a final diagnosis of acanthamoeba meningoencephalitis with no granulomas in an immunosuppressant female was made. Now to further discuss the management of acanthamoeba meningoencephalitis. The treatment remains challenging and is not standardized. Currently 10 to 15 different antiprotozoal, antifungal and antibiotic acting on diverse cellular pathways are used in various combinations. So what are the challenges in establishing the treatment guidelines? Number one, cases are extremely rare, thus making the randomized control trials infeasible. Number two, disease has a high mortality rate exceeding up to 90%, thus making it difficult to allocate potentially life-saving medications, ethically challenging. Third, treatment involves multiple medications simultaneously, thus making it difficult to determine the efficacy of individual drugs difficult. Publication bias, underreporting and lack of notifiable status of free-living amoeba further complicates the establishment of treatment guidelines. This results in reliance on case studies of survivors and in vitro research for therapeutic advances. To begin with, these are the drugs used in treatment for acanthamoeba, namely azoles, pyrimidine derivatives including trimethoprim, sulfadiazine, albendazole, anti-leishmanial agent amphotericin, miltefosine and antibiotics like rifampicin, macrolides and metronidazole. Due to the absence of any established treatment guidelines, we needed to review the literature to form our management strategy. We came across this study which was conducted in France and was published in the year 2022. Here they reviewed 474 clinical cases of free-living amoeba, out of which 119 were of acanthamoeba. They determined the frequency of usage as well as efficacy of the main drugs and drug combinations. The efficacy of the drug usage was determined based on the survival rate after drug administration. All of the above drugs were used in different combinations in the clinical cases studied in this study. They were used in different combinations and the efficacy was determined on the basis of patient recovery outcomes. And the recovery outcomes stated the efficacy, and that lead to crediting individual drugs that were taking part in each combination. So this study concluded that cotramaxole was the most frequently used but had a survival rate of 47%. Amphotericin is the second most frequently used, showed an intermediate efficacy with 30% survival rate. Rifampicin had an efficacy of 50% and is also one of the most frequent and most efficiently used drug in acanthamoeba. Fluconazole and ketoconazole were the most efficient azoles. Sulfadiazine displayed an intermediate efficacy of 33%. Metronidazole, although had a low frequency of usage, but it exhibited an efficacy as high as 45%. Miltefosine showed the highest efficacy of 55%. These were the three main drug combinations which were the most common and efficient among the 119 clinical cases studied, namely A, associating rifampicin, cotramaxole with fluconazole or ketoconazole, which showed an efficacy of 83%. The other similar combination associating amphotericin B, rifampicin, cotramaxole was also used, but it showed a lower efficacy of 50%. Additionally, an association of fluconazole, metronidazole, cotramaxole with either miltefosine or rifampicin was also used with a positive outcome in 100% of the patients. We also reviewed this Indian literature, which was this was a study conducted in PGI Chandigarh and NIMHANS Bangalore and was published in the year 2022, where they studied 42 cases of acanthamoeba, out of which only 50% of them survived. They have also reported that the main favorable outcomes were after the combination therapy with cotramaxole, rifampicin and ketoconazole or amphotericin. So after reviewing the IDSC guidelines and CDC guidelines which recommended similar drug combinations, we formulated this particular regime for our patient, which included rifampicin in the dose of 10 mg per kg per day once daily for 28 days, fluconazole 10 mg per kg per day once daily for 28 days, cotrimoxazole including trimethoprim in the dose of 20 mg per kg per day, and sulfamethoxazole in the dose of 100 mg per kg per day once in 2 divided doses for 28 days, metronidazole in the dose of 7.5 mg per kg once every 6 hours for 21 days, amphotericin B, we use conventional amphotericin B in the dose of 1.5 mg per kg in 2 divided doses for 3 days and 1 mg per kg once daily for 11 days for 14 days. To summarize, there is no effective treatment guidelines existing for acanthamoeba meningoencephalitis. Therapy should aim for amoebicidal drugs that cross the blood-brain barrier. Steroids may be used for cerebral edema. Even with treatment, prognosis is generally poor with the mortality rate exceeding up to 90%. With this, I would like to invite Dr. Simran Panwar from Department of Medicine to...
Thank you, Dr. Kanika. Good morning, all dignitaries, teachers and colleagues. So, let's discuss the progress of our patient after initiating treatment. From day 3 to 6, the patient was still febrile, she was drowsy and not obeying commands. On investigation, her WBCs did show a declining trend from 17,000 to 13,000, and her blood and CSF cultures were negative.
How will you explain low sugar in protozoal infection in CSF?
So specifically,
bacterial infection, it is fine. What
yes,
is the
sir.
findings of having low sugar in CSF in protozoal infections?
So, low sugar is mainly manifested in... As for the management, along with the treatment initiated, discussed by neurology, we also initiated combination antiretroviral therapy. From day 7 to 9, the patient was still febrile, she was drowsy but arousable and not obeying commands. From day 10 to 13, she was afebrile, she was conscious, she started obeying commands, recognizing her relatives and sitting up on her own. Her WBCs were on a persistent decline. On day 15, she was finally afebrile, she was conscious, oriented, obeying commands, and she started walking on her own. Her WBCs were within normal limits, 8,000. At this point, the patient was discharged. She is currently under follow-up and is doing well. So, we have presented to you a case of amoebic meningoencephalitis. This manifests in humans in two forms, primary amoebic meningoencephalitis and granulomatous amoebic meningoencephalitis. In our patient, we were dealing with acanthamoeba, which causes granulomatous amoebic encephalitis. This predominantly affects immunocompromised individuals. Unlike Naegleria, it is not associated with exposure to fresh water. There are less than 200 reported cases in the world, and most cases are reported post-mortem. So why is there such a high fatality associated with this infection? Acanthamoeba has a non-specific and progressively worsening clinical course, with clinical features ranging from low-grade fever and headache to focal neurological lesions and eventual coma and death. Most patients die in less than a month after onset of neurological symptoms. There is a diagnostic dilemma associated with the disease. CSF, specifically cytology and biochemistry on its own, are often inconclusive. Trophozoite census can be visualized on wet mount, but they may be confused with macrophages. Imaging is non-specific. Brain biopsy is an invasive procedure which can be done, but while it can visualize trophozoites, often it also shows non-specific changes of inflammation and necrosis. Culture, direct immunofluorescent antibody detection and PCR all are definitive, but they are only available at select centers throughout India. As for the therapeutic dilemma, the medical part has already been discussed. A surgical excision is also often required, and it is also not definitive on its own. For most of the cases, granulomatous mass excision along with chemotherapy are required for the survival of the patient. Review of literature. So this being an extremely rare case, there is no literature on the worldwide prevalence of infection. The largest study we could find was this, published in Open Forum of Infectious Diseases, Feb 2024, based on cases reported to the CDC. It reports a mere 122 cases as of 2020. And among this already very small number, 80 patients were diagnosed post-mortem, which leaves us with only 42 patients on whom treatment was attempted, and there were only 7 survivors, which means that the disease has a survival rate of 16% after initiating treatment, and there is a mortality rate of over 90%. As for the Indian perspective, this is from the Malaysian Society of Parasitology and Tropical Medicine, published in December 2021, which reports 42 cases from India. There were 64% males, 36% females, and majorly from New Delhi, 17 patients. Among these, 1/4 patients were diagnosed post-mortem, 21 patients survived, and 8 patients succumbed despite initiating treatment. Despite having only 42 cases published till 2021, within the last 3 years, there have been 9 published cases of GAE from India, especially from the southern and eastern regions, which implies that both the incidence and awareness of the disease seems to be on the rise. Even Naegleria, which is another fatal free-living amoeba, has total 25 documented cases so far and has been reported 4 times within the past 3 months, with 3 mortalities, most of them being teenagers and children. So this is an emerging infectious disease that warrants clinical attention. The learning points of our case are: granulomatous amoebic encephalitis is an under-recognized, extremely fatal and poorly understood infectious syndrome. Clinicians should consider amoebic infections.
So again, can you tell me, she was having oral ulcers frequent for 3 to 4 months.
Yes, sir.
What was that pointing now with this diagnosis?
So we attributed it to HIV, sir. She was
virus.
Yes, sir.
And that leads to the immunocompromise,
Yes,
whether
sir.
after superimposition of the pyogenic or bacteria or amoebic, that is different.
Yes, sir.
But the suspicion should be there of the virus, and then that.
Yes, sir. She had a acanthamoebic encephalitis with a background of HIV, which
HIV.
caused her to be immunocompromised, leading to the infection.
पहले जो डाउट जाना चाहिए था ना कि वायरस की तरफ जाना चाहिए था. रिपीटेड
sir.
जो HIV जो भी है, HIV है चाहे herpes simplex है चाहे कोई और है, ठीक है.
Clinicians should consider amoebic infections in the immunocompromised host with a CNS infection refractory to traditional therapy or with an inconclusive CSF. A wet mount preparation must be a routine part of the CSF examination. We are very grateful to the Department of Microbiology for suspecting and timely diagnosing acanthamoeba in this case, which enabled us to quickly initiate treatment and save our patient. Due to lack of consensus on therapy, treatment has to be individualized. Even after initiating treatment, survival rate is as low as 16%. Clinical awareness and vigilance are key to preventing mortality. I would like to conclude this CCR by expressing my sincere gratitude to MGUMST management